So why don't we get started? And I'm very pleased that we have Elizabeth Shane this morning, who has agreed to come from Columbia. We always should interact with our colleagues in the city, where she's professor of medicine, and she has got her medical degree at University of Toronto and started her internship there. And I met her when she transferred to Columbia to our residency program. And Elizabeth was my resident in the old tough, terrible days where we were on every third and every other. And I have many fond memories of Elizabeth in those days. And she went on and did her endocrinology training at Columbia and has spent her career there becoming really a world leader in the study of osteoporosis, regulation of bone mass, and novel treatments for osteoporosis. We kind of got to reacquaint ourselves. She was president of the American Society for Bone and Mineral Research when I was president of the Endocrine Society. We were able to do some joint initiatives. And now she's going to come and tell us about what's, particularly in my practice where I see premenopausal women who have low estrogen, really the treatment of premenopausal osteoporosis, pathogenesis, and management. So, Elizabeth, thank you. Welcome.
Thank you very much for the kind introduction. I apologize for the date on this. I just gave endocrine rounds at Columbia and I forgot to change the date. So I did change the talk a little bit, but I forgot to change the date. Right, we have new data. Right. So here are my disclosures. And just start, to sort of orient everybody to things that are self-evident, but especially for the fellows, about osteoporosis. As you know, it's a skeletal disorder. With the definition, I think is a terrible definition, but this is what it is in terms of the NIH consensus. Skeletal disorder characterized by compromised bone strength and predisposing to an increased risk of fracture. And here we have more of a realistic definition. Just looking at it, you can see that the microarchitecture of the bone and osteoporotic bone is really basically destroyed, and obviously this makes the bone weak. I thought I would start with a case of one of my patients who came to me years ago when she was 29, and she was a lovely young woman. I still, I take care of her still years later, but at 29, she was seated on a low windowsill, and she slipped and broke her hip. And the surgeon thought the bone was soft when he went in to pin the hip, so somebody got a DEXA scan, and indeed she had Z-scores, DEXA Z-scores. Remember, we use the Z-score in premenopausal women, which compares them to age-matched controls, which were more than 2 standard deviations below the mean for age at the spine, at the total hip, and at the femoral neck, where it was even 3 standard deviations below. This was a puzzle. She had absolutely no significant medical history. She didn't take any medications associated with bone loss. She did have a slightly delayed menarche, which can be associated with mild low bone mass, but certainly not at the level of this. She had regular periods after that, no amenorrhea, and she did have a positive family history of osteoporosis. She'd had no prior fractures. On a physical exam, she was very slender, but well-muscled, well-nourished looking. She did not have any stigmata of Cushing's, no oblique sclera suggestive of OI, no evidence of Ehlers-Danlos with joint hypermobility, no kyphosis, and no bone tenderness suggestive of osteomalacia. She had a very thorough evaluation for secondary causes of bone loss, and basically everything was normal. Her routine labs, her mineral metabolism labs, and her bone turnover markers, which were in the premenopausal range. We did a bone biopsy, and after tetracycline labeling, which you'll recall labels the bone-forming surfaces, where active bone formation is taking place, and we give 2 labels separated by 10 days, and then measure the amount of bone that is formed between those 2 labels. And we saw that she had very thin porous cortices, thin, disconnected trabeculae for a young person, no osteomalacia. This is the osteoid here in red, this mineralized bone, and there was certainly a normal amount of osteoid. But on her dynamic parameters, she had a very, very low bone formation rate. You can see the tetracycline labels here. You can barely see any distance between them. So in those days, we really didn't have that much to offer, so we just managed her conservatively with calcium, vitamin D. She was taking an oral contraceptive anyway for birth control. Over the next 3 years, we followed her. Her bone density remained stable. She didn't have any new fractures. She went on to have 2 pregnancies, both of which she insisted on breastfeeding afterwards, even though we know that breastfeeding causes a marked decline in reversible decline, but a decline in bone mass. She didn't have any fractures. And over the years that I followed her, she had several negative repeat evaluations for secondary causes of osteoporosis, and I'm going to come back to her a little bit later. So just to talk a little bit about the diagnosis of osteoporosis, in postmenopausal women, we have criteria by which we diagnose osteoporosis you're all familiar with. T-scores by DEXA, we diagnose it by T-score, being more than 2.5 standard deviations below the young adult mean at the spine, hip, or forearm, plus or minus a fragility fracture. And we can do this because there are a plethora of epidemiologic studies that validate the associations between bone density and the other various risk factors and incident fractures in postmenopausal women. But really, we have no comparable data in premenopausal women, which creates a difficulty in diagnosis. And then in terms of treatment, we have defined indications for treatment of osteoporosis in postmenopausal women, a low areal bone density T-score below minus 2.5, or low trauma fractures, or even an elevated fracture by FRAX or other risk assessment tools. But again, in premenopausal women, we don't have any clear intervention thresholds. So what I'm going to do today is talk a little bit about the diagnosis and etiology of osteoporosis in premenopausal women. I'm going to talk about one of the areas that I've been very actively investigating for the past 10 years, idiopathic osteoporosis in premenopausal women and some of our data. And then I'm going to talk a little bit about management of osteoporosis in premenopausal women with secondary osteoporosis and with idiopathic osteoporosis. Yes?
Before you go forward in the history, was there acute, severe stress during puberty or pre-puberty?
Emotional stress? Or
emotional stress?
Not that I didn't ask, so there could well have been, but I don't really know the answer to that. Why do you ask? So anyway, first we'll talk about the whole issue of osteoporosis in premenopausal women. It's really uncommon, and in fact, you know, in the old days when DEXA was first out there, we used to measure bone density in premenopausal women, and along around the mid-2000s, it became clear that this was not a cost-effective thing, so we don't even really encourage measuring bone density in premenopausal women because it's so uncommon. The diagnosis is really much more certain if there's been a low trauma fracture, and there are difficulties in trying to make the diagnosis on the basis of a low bone density. As you're all familiar with the World Health Organization T-score categories, which compare people's bone density to the mean bone density of the population age 30, osteoporosis is diagnosed with a T-score of minus 2.5 or below, normal bone mass with a T-score of minus 1 and above, and then we have this sort of gray zone in the middle, or yellow zone, I guess, which we call osteopenia or preferably low bone mass. And these cut points were developed in postmenopausal women and were never intended and shouldn't be used to characterize bone density measurements in premenopausal women. And the ISCD, or International Society of Clinical Densitometry, guidelines for premenopausal women suggest that we use the Z-score, as I mentioned a minute ago, not the T-score. And remember that Z-scores, as I mentioned, compare individual bone density to bone density of an age-matched normal control population. And in premenopausal women and men below age 50, we are supposed to report z-scores above -2 as within the expected range for age, because basically it's a standard deviation score, and below -2 reported as below the expected range for age. And we try to avoid the term osteopenia because we're really probably at this age looking at natural variation in bone density, and we don't really want to medicalize this whole situation and cause people to panic that they have the dreaded osteopenia. This does not apply to perimenopausal women. In perimenopausal women, the ISCD and the International Osteoporosis Foundation both recommend that we use the T-score in a perimenopausal woman. So the problem with low bone density alone in a premenopausal woman is that it can be due to a variety of things that are not necessarily reflective of poor bone quality. One is that they could just have low peak bone mass, and we know that genetic issues account for up between 50 and 80% of peak bone mass, and so it's possible that this is just familial low bone mass, and their microarchitecture could be completely normal. It could also be due to suboptimal bone mass accrual during adolescence because of either some insult that happened during adolescence when most of the bone that you're ever going to have is being laid down. It can also be related to small stature because the DEXA is a two-dimensional measurement of areal bone density. It measures 2 dimensions, and it really doesn't take into account the thickness of the bone. And in the small people, which I define as under 5'3", for obvious reasons, it may underestimate bone density in small people, and conversely, in very, very tall people, it can overestimate bone density, a volumetric bone density. There also can just be related to the statistical definition of a T or a Z score, because in a population of normal women, 2.5% are going to have a Z-score below -2, and 0.5% are going to have a T-score below -2.5. And if you look at a huge population, that's a lot of people. So as long as nothing else has happened and they have just a mildly low T-score or Z-score, then you might not be too worried about that. Then there's also this disorder, sort of ill-defined, I think, called constitutional leanness, which has been defined in the 2000s as a non-pathological state of underweight, which is often familial. All these like very, very slim people who just seem to be naturally slim and never went on a diet in their life, but they have regular periods, always have regular periods. They have low bone density by DEXA, but by high-resolution peripheral QCT, which can look at the quality of the bone, they actually have abnormal microarchitecture. So I don't think there's been too much new about this, and I'm not really sure I understand exactly what it is, but it can be another reason for low bone density. And the reason we care about it, I don't think anybody knows. I'm not aware of any biopsy studies, and bone turnover marker studies in that age are pretty unreliable. So the issue is that low bone density in a young woman is really not associated with the same risk of fracture as it is in an older woman. And that's for probably a ton of reasons. Young women are estrogen, they have more muscle, they have lower bone remodeling, their bone cortices are thicker, they have better bone structure, and also they have many fewer falls. And for probably a lot of those reasons, the incidence and prevalence of fractures is much lower in premenopausal than postmenopausal women, even when the bone density is very low. And so you can see here that for a given bone density, the risk rises with age. Here we have a very low bone density, here -3, and here you have your hip fracture rate percent per 10 years, and look at an 80-year-old with exactly the same bone density, and you can see that there's just light years difference in the much lower risk of fracture in a young woman than an older woman, even though they may have a very low bone density. And if the sine qua non for treatment is to prevent fractures, you have to treat a lot of people this age with low bone density to prevent fractures, whereas not so much in an older person. So how do we make the diagnosis? By the ISCD criteria, we use either a Z-score of -2 or a T-score of -2.5, depending on the organization. plus a secondary cause of osteoporosis. So if you know there's a reason for this person to have osteoporosis, and they in fact have a low bone density on a DEXA scan, then you can assume that they have osteoporosis, and we all know the major causes: hypogonadism, glucocorticoids, etc. Or if they have a history of a vertebral or a non-vertebral low trauma fracture or fractures at a major site, whether or not the bone density is frankly low, then you should be thinking about osteoporosis. So what about women with low bone density and no secondary cause and no fractures? Well, neither of the two major organizations would say that such a woman has osteoporosis, and I'm not sure that that's really right, but over the global population sort of perspective, it's probably right in most people. So what do we do to evaluate a premenopausal woman who does present with either a low bone density or fractures? The goals for the fellows, you really want to focus on identifying secondary causes of osteoporosis, especially if they're treatable. And there's a slew of them. I'm sure this is not really even complete yet, but or there's constantly new things being added. But don't lose heart. These are the most common, based on several studies. And the most common are glucocorticoid excess, either endogenous or iatrogenic, or premenopausal estrogen deficiency, followed by the obvious players: GI disease, medications, alcoholism, which I think is sort of somewhat of an increasing problem in the young people. I think there's an awful lot of binge drinking and teenagers and college students and young adults, and I've seen several patients who've come in with profound alcoholism to the extent of even liver failure with profound osteoporosis in their 20s, primary hyperpara, OI, and then idiopathic. So who should be evaluated? Anybody, I think, if they have a bone density that is low for whatever reason it was measured, well, a good reason or not a good reason, I think they deserve an evaluation, because it's very possible that there's some correctable, treatable cause that could be addressed that they were unaware of. And then if they have a fragility fracture, or especially a prevalent vertebral fracture, is extremely uncommon in this age group and generally indicates that there is a problem, regardless of their bone density, then they should be evaluated. And the IOF suggests they should have actually more than one fracture to warrant a workup, but the ISCD says one is enough. How often you find a secondary cause kind of depends on the type of practice you have. So if you look at the population-based study, which is the only one I'm aware of out of the Rochester, Minnesota Epidemiology Project, in a large study of men and women between the ages of 20 and 44 with fractures and low bone density, 90% of people in a population have a secondary cause. But when you look at tertiary referral centers like yours and like mine, then only about 50% have a secondary cause, because obviously if it was easy, why would they come? So generally the evaluation is pretty straightforward. Just evaluate them take a good history, look for things like sort of early tooth loss or kidney stones, which that could suggest OI. Kidney stones could suggest idiopathic hypercalciuria, which is associated with a low bone density and fractures. And then the physical, just rule out obvious things like Cushing's and thyroid hormone excess, some zebras like systemic mastocytosis, where you will get urticaria and dermatographia, and then features of connective tissue disorders. The exam, obviously just rule out the common things. This is an initial exam, and then I always get a 24-hour urine for calcium and creatinine. While I'm at it, I get a free cortisol because it's such a nuisance to have to collect one, even if they don't really look cushingoid. Or if that hasn't been done, then we can get a salivary-free cortisol. But I always get the 24-hour urine for calcium and creatinine because hypocalciuria in a 24-hour urine, or conversely hypercalciuria, can send you down a different investigative pathway. And then, as indicated, depending on the history and physical and the routine labs, these other things that sort of, like if they look like they've got celiac disease, you might be more into the vitamin D, PTH way. And obviously, if you think they've got some kind of strange hematologic problem, et cetera. So a lot of people are coming either asking for or having already had whole exome sequencing for mutations in WNT or LRP56 or other genes that have been associated with low bone mass. And that's probably going to be what we do in the future as precision medicine takes hold. Bone turnover markers, I think, are pretty basically useless in this situation. If they're low or normal, you could hypothesize that this suggests prior bone loss or low peak bone mass. If they're high, it could suggest that bone loss is ongoing and whatever insult is going on is active. But you know, there's just a lot of problem. They have a wide normal range. They're quite variable. They have to be collected in the morning, fasting, because they're influenced by food intake and diurnal variation. And they're physiologically higher in growing young adults. And also they're high after fractures. So somebody presents with a fracture, it's going to be artificially high. Bone biopsy, you know, we can do them, so we do sometimes, but it's not widely available. So in my opinion, it's more of a research tool, but I do think it can help guide you in a way that bone turnover markers and other tests cannot, if nothing else can be found. And so I would say if you can do it, and then it could be a good idea in patients who have unexplained low trauma fractures. And occasionally it does identify another source of bone fragility. And in our studies, it really was categorized people as low or high remodeling at the tissue level. And it turned out to be more accurate, at least in terms of what was going on at the biological level, than the bone turnover markers. Okay, so I'm just going to sort of summarize some of our studies in idiopathic osteoporosis. So what is idiopathic osteoporosis? It's really kind of an operational definition that I kind of made up. You know, and I think other people agree, but it's really occurs, it's said to occur in men under 50 and premenopausal women who are otherwise healthy, who have normal gonadal function as far as we can tell. They have normal measurements, and the women are menstruating normally, and no secondary cause of bone loss after a thorough evaluation. So it's probably a grab bag of different things that don't really come to clinical definition. These people are generally Caucasian. They typically present in their mid-30s with one or more low trauma fractures. They usually cluster over 5 to 10 years. And they may present, we think, during pregnancy and lactation, because there is an entity called pregnancy and lactation-associated osteoporosis, in which people will have multiple vertebral compression fractures immediately in the third trimester or immediately postpartum while they're breastfeeding. And who knows what their bone density was before they went in. We don't know whether it was low and then the stress of increased remodeling during that period caused them to fracture, or whether this is an actual separate entity. And it can be mild with just one fracture, or it can be devastating with multiple, up to eight. I have patients with up to 8 vertebral compression fractures. What about women with isolated low areal bone density but are otherwise healthy? We don't really know what this means. Does it mean that their short-term fracture risk is increased, and is their microarchitecture normal or normal? And so one of the problems we tried to address, or issues we tried to address in our studies, was what is the microarchitecture and strength like of young women who have low bone density but who haven't fractured, or at least haven't fractured as adults. We did a cross-sectional case control study that was supported by NIH in 2005. We had 3 groups: a control group of 40 normal women with no fractures and normal bone density, a fracture group, which was 45 women with anywhere from 1 to 12 adult fractures. Most had multiple fractures. First fracture occurred about age 30, and the fracture types were all over. If they were minor fractures, they also had to have low bone density. And then we had a group which was really hard to recruit, because this is the time when suddenly everybody said, don't measure bone density in young women. But so we only were able to recruit 19 of them. They didn't have any adult fractures, but a few had low trauma adult fractures, and a few had high trauma fractures, like from a motor vehicle accident or skiing into a tree or something, and about a quarter had had childhood fractures. And the groups were well matched in terms of age and height. but the control patients, subjects were heavier and had a higher BMI than either of the other groups. So all of our analyses are controlled for BMI. So just to summarize a lot of data, that we didn't really find that many differences in either the fracture or the low BMD group versus control. There really weren't, despite the differences in weight, a lot of differences in trunk fat or whole body fat or reproductive history and any of the usual metabolites, and most bone turnover markers were similar. They had slightly higher but eminently normal PTH levels in the 30s or high 20s. They had slightly higher but normal TRAP5B, which is a marker of osteoclast action. And there were direct relationships between osteoclast activity as assessed by C-telopeptide and TRAP5B, and also bone formation markers and the PTH. But these were all within the normal range. They did differ by family history of osteoporosis, which not surprisingly was more frequent in the patients than controls. And they also had more SSRI use. That was a trend towards significance, although not significant. Now, men with idiopathic osteoporosis have been well defined in the past, and the vast majority of them have normal testosterone levels, but low serum IGF-1 levels, whatever that means. It's very hard to know what low serum IGF-1 levels mean, especially when you think of it in the bone microenvironment and what it's doing there and how those levels relate. But in men with idiopathic osteoporosis, they have low bone formation, low IGF-1 in the serum, and there's a direct relationship between serum IGF-1 and bone formation rate. So we kind of expected that we would see that in our women with IOP, and we didn't really find that. There was absolutely no difference in the serum IGF-1 level, and there was no association with age-adjusted bone turnover markers in any group, and no association with bone density. So this was quite a difference between men and women with IOP. Obviously, bone density was lower in the two affected groups than the control group. We also decided to look at volumetric bone density as opposed to areal bone density. And so we measured bone density at the spine and hip by central QCT, and we also measured at the peripheral sites, the radius and tibia, by high-resolution peripheral QCT. And at the spine, we measured trabecular volumetric bone density, and at the hip, where there's more cortical bone, we can actually measure trabecular and cortical volumetric BMD and cortical thickness. And this data is expressed as percent lower than controls, and the fracture group is in blue and the low BMD group is in orange. And at every point, at every site, volumetric bone density was lower in the affected patients than the controls, and certainly just as low, if not lower, in the low BMD group than the fracture group. So it wasn't just that these people had like a low areal bone density, but their volumetric BMD was okay because they were smaller. It was that they really had lower volumetric bone density too. They also had lower cortical thickness, less cortical bone, and when we measured stiffness by finite element analysis, it was also lower. And then what we did was we sort of developed used the QCT scale results from the controls to calculate sort of a Z-score for the IOP subjects. And we found that at the spine, 18 of 19 subjects who had a Z-score below -2 by DEXA also had central QCT Z-scores below -2. So even though we sort of take the DEXA with a grain of salt, at least in this group, it seemed as though it actually was telling us something about the true volumetric bone density. And the positive predictive value of DEXA for a Z-score below -2 by central QCT was 95% at the spine, 90% at the total hip, and 86% at the femoral neck. We looked at bone microarchitecture at the peripheral skeleton by HRP-QCT, which is a small CT scanner that we have in our bone unit, and it measures bone quality and bone microarchitecture at the distal radius and distal tibia. And this is just what the scans look like. This is a normal one. You can see very nicely the cortex and the trabecular bone. And here we have a fracture, representative fracture patient and a representative low BMD patient. You can see the cortices are much thinner in both groups, and you see the central trabecular dropout with fewer trabeculae more widely spaced. We did transiliac crest bone biopsies in everybody, and here we have micro CTs of the cores, of the biopsy cores, and you can see this is a control patient, here's a fracture patient, and here's a low BMD patient. So it looks as though, and here we have the cortices, representative biopsies of the cortex, and here you can see that the cortex is much, much thinner and more porous in both the affected groups of patients. So just to summarize all those data, no matter how we looked at it by 3D imaging, whether we did central QCT, peripheral QCT, and bone biopsies, we found, compared to controls, that in cortical bone, they had lower density, thickness, and increased porosity. In trabecular bone, lower density, fewer trabeculae, more widely separated trabeculae, and lower stiffness. And that the deficits we found were comparable in both the fracture patients and the low bone density patients. In terms of bone remodeling, it was really heterogeneous. We didn't really see any significant group differences between the controls and the fracture of the low BMD, but there was a lot of patients with high normal, and this is the shaded area represents the normal range based on our controls, and you can see that a lot of them were in the normal range, and some were low and some were high. And what we seemed to find was that there were differences in whether or not in potential causes, depending on whether they had low or high remodeling. And so the women in the lowest tertile actually had the worst trabecular bone volume thickness and the worst, lowest stiffness and low osteoid width and wall width, which are consistent with osteoblast dysfunction, which goes along with having low bone formation in the. And they also had, back to the IGF-1 story, they had higher IGF-1, which is the opposite relationship that we saw in men. So in men, low IGF-1, low bone formation. In these women, we had higher IGF-1 and lower bone formation, which kind of raised the question of, could there be some kind of resistance to IGF-1 signaling at the osteoblast level? Whereas the women in the highest tertile, they had less severe deficits in bone volume, higher urine calcium and PTH, higher 125D, consistent with perhaps a mild idiopathic hypercalciuria. So I think that the biopsy can tell you some things that maybe the general workup might not be able to show. What about bone formation markers? Did they predict bone formation on the iliac crest bone biopsies? Really, no. You can see here that even though in the low turnover, middle, and high turnover group, the means might be different, you can also see that there's really a lot of overlap. And in the individual patient, you couldn't really say that a bone turnover marker was reflecting what was going on at the tissue level. We also looked at marrow fat using the method of Said et al. You can see these are fat cells in the marrow of a control patient, and you can see there's way more fat in the marrow of the IOP patient. And we looked at adipocyte parameters in terms of their percent different from control, and they were all higher. The amount of fat, the perimeter of the size of the adipocytes, the number of adipocytes, the density, and marrow volume. And this was significant also after you controlled for age, BMI, because obviously marrow fat goes up with age, and even when you controlled with bone volume fraction. So it's not just that there was more fat because there was less bone, there was more fat even though there was less bone. So just to summarize our findings about IOP, that there were pretty consistent deficits in volumetric BMD, microarchitecture, and stiffness everywhere we looked. The spine, the hip, the peripheral skeleton, and the iliac crest, and heterogeneous turnover, which suggested varying pathogenesis. A group with very low turnover suggesting a primary problem with osteoblast dysfunction and possibly IGF-1 resistance, and a group that looked like they might have mild idiopathic hypercalciuria. They had higher marrow fat, and I didn't show you these data, but we also analyzed their bone matrix, and they had less mineral and more mature collagen crosslinks than control patients. So there's a variety of differences. Can't really explain them all, but they certainly all differed, and there were really no differences between the fracture and the low BMD group. So we conclude by thinking that bone biopsy actually, it's not a commonly used tool, but it could be helpful in women like this. And measurements of bone turnover markers aren't really that helpful. And that, as I said, the fracture in low BMD patients didn't really differ. And I don't know whether this is a small study. Obviously, most bone biopsy studies are small. We got, 104 biopsies, so that's pretty good, but still pretty small in the general scheme of things. We don't really know if this is part of a continuum. We don't know whether the fractures are due to happenstance. Most of us who see osteoporosis patients have people with horrible bone density who never fracture, and conversely, people who fracture with not so horrible bone density. So it's not really clear what this all means. Now, turning to management, it's really a challenge to manage these patients. It's getting more challenged to manage post-menopausal osteoporosis. So this is really even more challenging than that. So I think, since we have issues trying to manage older women and don't know when to start necessarily, putting them on medications and how long to treat, and et cetera, which is the subject of about 3 more talks, in a young person, these issues are even more important. And so first of all, I think it's important, you have to decide whether you're going to treat, obviously. And then once you decide that you have to treat, then what might you use? So I'm not saying they should be treated. I'm just going to show you some of our data showing what one might do. And we're trying to get data on at least doing something. Not that it may be the right thing for your patient, but at least there'll be some data out there to use. So obviously general measures like nutrition, calcium, vitamin D, and exercise, and avoiding known skeletal toxins like tobacco and alcohol excess. And I mean, we recommend this for everybody, and it makes sense, but you have to counsel your patients that has very minimal effect on bone density. And so they're going to be good for a year or two and come back and have high hopes their bone density is going to go up by 10%, and it really probably isn't going to change. And so they need to not have such high expectations. There's not very many data available on conservative treatment in premenopausal IOP. There's just one tiny observational study of just 16 women who were followed with calcium D and exercise for an average of 3 years. And their bone density didn't go down on average. It went up a little bit at both the spine and the hip, and there were no new fractures. So, at least that's a little good news, but it's not a lot of good news. In general, if there's a secondary cause, it's good to identify it and treat it if possible, because often treating the secondary cause yields large increases in bone density, more than you would even get with a bisphosphonate, for example. So this has been documented in celiac disease, although it's certainly not always the case that bone density improves after gluten-free diet, but often it does. In primary hyperparathyroidism, bone density usually goes up after successful parathyroidectomy. In patients who have inflammatory disease and the inflammation is controlled with biologics, like rheumatoid arthritis and inflammatory bowel disease, just controlling the inflammation and TNF levels and IL-6 levels can improve bone density. So it's good to treat the underlying cause, and that should be your goal in a patient with a treatable underlying cause, rather than giving them a medication. In my opinion, it's rarely justified to treat premenopausal women with osteoporosis unless they're having fractures, or you're following them over time with conservative therapy and they're having bone loss, or they have an extremely low T-score and Z-score, and I just think, sort of teleologically, -3 would be where I would start to get, twitchy, I think just a couple of other points about treating in general: avoid SERMs. because they cause bone loss in premenopausal women. They bind to the estrogen receptor and are less potent than estrogen, so it's been well documented that they cause bone loss. Shouldn't be used in premenopausal women for this purpose. They obviously have a role in breast cancer treatment, but not here. And then, of course, bisphosphonates we have to use with caution in childbearing women because they have their long residence in the skeleton, and they break down with, they get released with remodeling. So in the last trimester and during lactation, they can cross the placenta. And in animal studies, there have been adverse effects noted on the fetus in high doses. There's tons of case reports. Most of them suggest things are safe, but you know, God forbid that you decided to treat somebody and something went wrong. I think you'd not be on strong ground. And of course, denosumab and teriparatide are contraindicated during pregnancy. I'm going to show you some data on the former in our patients. Oh, this is just the slide showing the decrease in bone mass on raloxifene in 27 premenopausal women. There is a nice review, it's a little 5 years old now, but in Osteoporosis International by Ferrari and colleagues, looking at all the studies that look at bisphosphonates or teriparatide in premenopausal women with secondary osteoporosis. These are the causes. And basically, they all improve bone density. The caveats are that they're only FDA approved in premenopausal women taking glucocorticoids, and that there are no data that bisphosphonates or teriparatide prevent fractures in premenopausal women, and there's probably never going to be data like that, because if it takes, 10,000 women to show, postmenopausal women to show fracture risk reduction, you're not going to do a study. It probably takes 50,000 women to show a fracture risk reduction in premenopausal women because of the low fracture rates. So we have published in 2013 a study, an open-label study, observational study of teriparatide in our premenopausal IOP cohort. We had 21 of the women who agreed to participate. They're just under age 40 on average. They took teriparatide 20 micrograms a day for 2 years. We did bone densities every 6 months, transiliac biopsies, and HRPQ CT scans. We did baseline in 18 months for both of these. And you can see there was a nice about 11% improvement at the spine, 6% at the hip, which was pretty good for the hip, and about 8% at the femoral neck. So these are excellent responses. Here's our patient, the one I presented. She decided to participate in the study, and you can see that her bone density went up and on treatment, and her T-score went from a -2.6 to a -1.4 at the spine, so she had an excellent response. The paired biopsies showed increases in all parameters: bone volume fraction, trabecular number, cortical thickness, trabecular stiffness or strength. There was also an increase in cortical porosity, as we always see with teriparatide. And this is our patient's course, micro-CT course from opsiciliac crests. This one looks a lot better, although you have to use the caveat that they are from opsiciliac crests, so we don't know if we try to place it correctly, but it could be slightly different. There also were improvements in HRPQ-CT at both the wrist and the ankle, and improvements in strength there. We did see, however, quite a variable response. Yes?
Sorry, then did you give her an anti-resorptive after that?
I'll come to that. We also saw quite a lot of variability in response. We had about 4 of the 21 women who really didn't have any increase in their spine BMD at 12 months. And they also had no increase at the hip. The non-responders had significantly lower bone formation rate on the biopsy. Here's the cancellous bone formation rate in the responders and the non-responders, which is kind of sad since this is sometimes a low turnover and you're trying to stimulate it to improve bone mass and structure, and the group that has the lowest turnover is the most resistant. The bone density response correlated directly with the baseline bone turnover rate. So the higher your bone remodeling was when you started teriparatide, the better improvement in bone density you got. And what we found back to the IGF-1 issue is that the non-responders with the lower bone formation rate also had higher age-adjusted IGF-1, a little bit more of a suggestion that maybe this is resistance to IGF-1 and PTH signaling at the osteoblast level. And there was an inverse relationship between serum IGF-1 and bone density change at the spine by 12 months. We had circulating osteoblast progenitor cells, peripheral blood mononuclear cells. They also, we isolate them. They're RUNX2 positive, which is an osteoblast marker. We isolated them from PBMCs by flow cytometry, and we've shown in other studies that they correlate directly with bone formation on biopsies. And we used antibodies against the IGF-1 receptor on the COP cell surface to assess the relationship of the IGF-1 receptor to bone formation rate on biopsies and response to teriparatide. And in our 25 women with IOP who had bone biopsies after tetracycline labeling and who had the COP cells available, we grouped them by tertiles of bone formation rate, low, middle, and high, and we found that the COP cells were higher in the high turnover, and IGF-1 expression was higher on the high turnover, and serum IGF-1 was higher in the low turnover, so a little bit more evidence. And in the 11 women in this pilot study who were treated with teriparatide, we found a significant 3 months changes in both the COP cells and the IGF-1 receptor density on COP cells. The COP cells went up by over 200%, and IGF-1 receptor more than doubled. So, and we also found that this increase in receptor density predicted 6-month rise in bone density with strong R values. So a little bit of data there that we're following up in our newer studies.
Does that
So,
correlate with baseline bone strength?
yes.
In other words, the people with low formation begin with
Didn't respond as well. They didn't all not respond, but the ones who didn't respond at all had low bone formation rates. But we had other people with low bone formation rates that did respond. So you're back to your question about what about afterwards. So these women are all estrogen replete, and in postmenopausal women who who take a course of teriparatide and are on estrogen, they maintain their bone density. So we had hypothesized or hoped that endogenous estrogen production in these menstruating women might be sufficient to prevent the decline in bone density that goes after stopping teriparatide. So we did not routinely put people on anti-resorptive, but we were able to follow some of them. And we did have 15 women from the pilot study who came back at 2 years, and they had partial loss, 5% loss at the spine, but they didn't really lose anything at the hip. And those who lost the most were older, so they were mid-40s as opposed to late 30s. They may have had lower endogenous estrogen levels. So I think that probably premenopausal women will need some form of anti-resorptive therapy to prevent bone loss after teriparatide. So the question is, which anti-resorptive should be used? Estrogen, bisphosphonates, denosumab, maybe more anabolic therapy. So we're working on that now, and we have an ongoing study. Our ongoing studies include a whole exome sequencing of the phenotyped cohort of 104 women with IOP. That's in process now. We just looked at the data, and there are now we didn't find anybody with OI or anything that they might have had that a mild form, and we're now looking at the data with the genetic counselors. So that's in process, and we hope to have some information soon on that. We have an ongoing, almost completed R01, a randomized controlled trial of teriparatide in premenopausal women, in which we enrolled 41 women in a randomized placebo-controlled single switchover trial of teriparatide, and it's funded by the FDA. Primary outcomes and secondary outcomes are as you would expect. We did do a quadruple labeled transiliac biopsy at 3 months. So what we do there is we give a set of tetracycline labels before they start the teriparatide, and then after 3 months we give another set, and we do a single biopsy. So in one biopsy we can measure bone formation at the tissue level pre and post therapy, and so we have some of those data. Now we also we have so far 11 women randomized to placebo and 24 to teriparatide, and then we do switch, we do the tetracycline labeling and the biopsy, and here we have the quadrupled label biopsy before teriparatide. You can see here we have the labels, and you can see how much more labeling there is, after the teriparatide. And we have now data on that showing that the bone formation rate goes up in the teriparatide group, as you'd expect, at the cancellous, at the endocortical, and the intracortical surfaces. And we found that the absolute range, change correlated with the baseline bone density and the absolute change in CTX and P1NP. So those data are coming. We also are continuing to look at this IGF-1 question. If women with IOP, if they have low bone formation and high serum IGF-1, they could also manifest phenotype of patients with low IGF-1 due to adult pituitary growth hormone deficiency, and that would look like they had decreased bone density, low lean body mass, low visceral adiposity and insulin resistance, etc. And so we have an RO3 that is just now we're analyzing those data. We're comparing the people with low and high bone formation rate with respect to baseline and stimulated serum growth hormone, IGF-1, IGF-1 binding proteins, and fat distribution, adiponectin, etc. So those data should be reported at ASBMR this year. And we also have a phase 2b study of denosumab to prevent bone loss in premenopausal women treated with teriparatide, which is almost completely enrolled now. And we take the women who've completed the teriparatide study. It's actually up to 29 people have enrolled to date, and watching what happens with denosumab. And anecdotally, I can tell you that after they finish the teriparatide, their bone density continues to go up quite remarkably on denosumab. So what about after denosumab? So, there's been obviously recent reports of rebound multiple vertebral fractures after discontinuing denosumab. And so Amgen just did a reanalysis of their phase 3 fracture data, and that revealed a small but significant imbalance in multiple vertebral fractures after stopping denosumab versus those who were continued denosumab. And so we submitted an IIP to Amgen to test alendronate and zoledronic acid in the premenopausal women with IOP who completed denosumab, and we are now applying to the FDA for an R01 to do the same study with actually enough money to get it done. So hopefully, we'll at least get partly done. And obviously, whether or not a woman chooses or we think it's wise for her to go on a bisphosphonate will depend on a lot of factors. Obviously, if she's going to have a baby next year, that's not exactly what we want to do, but usually most of the women in our study are sort of past that phase, and a lot of them had pregnancy and lactation-associated osteoporosis and multiple vertebral fractures, so we're very concerned, and they're concerned about the possibility of this and most of them are not having children, so this may not apply to everybody. So, okay, and we have one other study that my colleague D. Cohen just got funded by the FDA on orphan diseases grant to look at pregnancy and lactation-associated osteoporosis. So just looking at the etiology, mechanisms of disease, and genetics, and if you have any patients with pregnancy and associated osteoporosis or lactation, we'd love to see them and include them in our study. So I think key diagnostic points that I made were the diagnosis is most secure of secondary cause of bone loss or low trauma fractures. Low bone density in otherwise healthy women should be interpreted with caution, but I think our data suggests that it may very well reflect low bone strength. Bone turnover markers are not of much assistance, but biopsies can be helpful. In terms of management, crucial to assess for secondary causes of bone loss and treat. Most women don't require bone drug therapy, especially if they just have low bone density. Reserving pharmacotherapy for fractures, declining bone density on treatment or very low bone density. I think that both anti-resorptive drugs and teriparatide increase bone mass, but we really don't know yet who best to use them in, and our goal is to try and at least provide some data for people who are trying to make the decision, as opposed to saying that everybody should be treated, which we clearly do not do, but we're trying to help in at least giving some data for people to look at when they're making their decisions. I'd like to thank our funding people and all of our research team, especially Adi Cohen, who's my longtime colleague at Columbia, and who really has been so important in doing all these studies and is now getting her own funding, and very excited about that. And thank you for your attention. I'm sorry I went over.